Let's do this. I don't remember this before. All right, everybody, this is Mr. Summers. I'm here with Dr. Mark Odland, who was the chief of surgery at Hennepin County Medical Center before he retired. He did both kidney transplants and trauma surgery. And I'm just gonna have him go through a couple things, kind of get you keyed in on what kidney surgeries were really like. Can you start, Dr. Odland, with your educational background?
Sure. I did graduate from high school. That was one prerequisite. So hopefully everybody has that as their goal. Then I went to St. Olaf College for 4 years. And right after St. Olaf College, I went to medical school at the University of North Dakota, which was another 4 years. And then I did a surgery residency at Hennepin County Medical Center, where I actually ended up working, for 33 years or something like that. But, but that surgery residency program was 6 years in length. So you can see, so after high school is 4 years college, 4 years medical school, and 6 years residency. So I got my first job when I was 32 years old, and that was going straight through school. And so then I had 2 years where I went back to my hometown in North Dakota and practiced for 2 years. Then I came back to Hennepin and did a kidney transplant fellowship and learn all about kidney transplants. And then I spent my career there doing kidney transplants. Of course, Hennepin County is the level 1 trauma center. So I did trauma surgery for 30 some years and also did general surgery. Just did, routine general surgery during that time also.
What does a kidney transplant fellowship entail?
It's more on the job training than anything else. I mean, you do need to have the background and a knowledge of the immunology of, because the kidney transplant, I mean, the surgery just gets the kidney there so it can work, but then it's the whole manipulation of the immune system, though, that makes it successful. So, my part was, doing the little stitches and doing the anatomical thing. But it's the medicines they take afterwards and the management of those medicines that really makes them successful for the long term. And there's lots of complications to the medication also. So, it's always a funny thing is, if I was going to do an operation on somebody and said, okay, I'm going to do a big operation on you, but I'm going to give you a bunch of medications that makes it so that you can't fight infection and you can't heal properly, and say you're crazy. But that's actually what we do when we do kidney transplant, is that the medication which inhibits the immune system, then so it doesn't recognize that kidney as not belonging to the patient that receives it. It's the same system that helps the body fight infection and healing process.
What was the normal, so what is the most common ailment that someone who needs a kidney transplant typically has?
The most common are people with diabetes, and that makes up about 1/3 of the people that need kidney transplants. And then, another, just a little bit less than 1/3 are people that have high blood pressure, and high blood pressure over the years has ruined their kidneys. And they tend to be an older group of patients because it's long term. And then there just gets to be a variety of different diseases. Some of them, lupus, some immunologic diseases, lupus, rheumatoid arthritis. Then there's some congenital diseases also. The most common is polycystic kidney disease, where it's an autosomal dominant disease that over years the kidneys just turn into big cysts, and then and the cysts take over all the kidneys in that. So those are the most common.
Now, since we've talked plenty of times in the 10 years of you knowing me, the biggest kidney you ever took out of somebody was how big?
Well, each of them were 25 pounds. And the patient was 6'8" and weighed about 280 pounds. And so he was a really big guy. And so he had a lot of space to put these kidneys, and so it was actually taking those massive polycystic kidneys out were one of my favorite operations.
For my students, if you have to picture somebody in your head, just picture Noah Pappas with giant kidneys inside of him. Dr. Odland, Noah Pappas is like exactly as you just said. I think he's like 6'7", and I think he might be 315, so he's a large boy. The actual process of taking out a kidney, do you take, so let's say you have someone with diabetes whose kidneys aren't functioning. Do you take both kidneys out? Do you leave them in when you transplant? Like, do you just put another one in somewhere else?
You know, we leave their kidneys in unless we have a reason to take them out, and it's not very common to have a reason to take them out. So we just create a new space to put the kidney in. And that's in the groin, so it's kind of like a hernia operation. So we expose the artery that goes to the leg, and then expose the vein that comes from the leg. And then when we're in the pelvis, we're really close to the bladder, so we can make a new connection directly into the bladder. The reason to take people's native kidneys out is if they have recurrent infection. And sometimes in the case when we talked about the polycystic kidney disease, that they're just so big that they occupy the space we need to put the kidney transplant in. And also people have recurrent infection. I don't know if I said that, or really bad high blood pressure. Those are the main reasons in that, so of taking kidneys out prior to transplant. But we wouldn't do it at the same time because of that issue of giving them the drugs that inhibit healing and inhibit ability to fight infection. So if somebody needs their kidneys out, we would take them out, usually give them 6 weeks to recover, make sure they're covered without any complications, and then do a kidney transplant or put them on the list.
You just, as you should know, because I think you understand our routine, Eleanor and Clark just started their bath time, so I'm sorry I have to keep muting myself. I had a question there. Can you just walk us through briefly the process of taking kidney out of somebody? I'm gonna have a link to a video too for my students to see, but if you can just, I don't know, like a brief synopsis of the procedure.
Yeah, well, when we get a kidney, there's two sources of donor. It's either live donation or someone who suffers a brain injury of some kind and has a non-survivable brain injury and brain death, and they remove them in a different way. And those, when somebody dies and they take their organs out, they try to take multiple organs. Try to use the liver for transplant, pancreas for transplant, heart and lung for transplant also. So it's a very different operation when they do that. When a relative or a friend is going to donate somebody, which is the live donor transplant, we would do that operation, laparoscopically. So we would make, multiple small incisions about an inch, put a TV camera inside, and then watching on a TV screen, and it's kind of a little bit like a video game. And these other little incisions have these special tubes that we put long instruments through. And then watching the TV screen, we manipulate the kidney until it's totally freed from the surrounding structures. And we have to protect those three structures that we have to connect, which is, the artery, the vein, and the ureter. And then they have really kind of these special instruments that were developed to, staple and divide those so they could be taken out safely.
Do you keep any part of the adrenal gland on top, or is that just clean cut off?
We go underneath the adrenal gland and leave that with the patient so that they can have that for the future, even though they wouldn't need it, but since they have two, but we leave that behind.
That was one of the most common questions from my students was, what problems do you have if you only have one functional kidney?
The kidney that's left behind actually increases in function over the next 9 months to a year. Now, it never gets back to do the function that two kidneys would do, but it increases its function to about half of what that kidney that was removed would do. So if they measured it at, 100% function, you took a kidney out one day, then you had 50% function. Well, you'd get back to like 75% function in the future than that. So, but luckily, our kidneys were, made with such reserve is that we don't get sick usually until that function is 10%, of normal, 10% of that 100, and sometimes even less than that. So people are left with 50% of their usual function. They can have a normal life.
I'm going to start now. Thank you again for all of those with the questions from my students. The first one was, why did you go into kidney surgery, not a different type, not trauma, orthopedic or like plastic or any of those other ones?
Well, sometimes a little complicated decision. Sometimes it's a little crazy. I actually, when I went to medical school, I was going to be an orthopedic surgeon. But there were 3 other guys in my class that wanted to go into orthopedic surgery. And I thought they were all kind of arrogant guys that I wouldn't, not that I disliked them, but they weren't people that I would like to have as friends. So because of that, it's a crazy reason, but because of that, I said I always wanted to be a surgeon. So I decided to go into the general surgery. And then, when at Hennepin, we had we did the first kidney transplants in the state, and so they had a pretty active kidney transplant program, and I really had no intention of being a kidney transplant surgeon. But when I was finishing my residency and training, they asked if I would stay on, and at that time I said no, but then they sort of persisted and recruited me back a couple years later to do kidney transplant and work in the surgery program.
Now the biggest kidney I know you said was 25 pounds each. Is there like a kidney that was like really gross or the worst kidney you had to ever take out?
I think there was, sometimes we'd have kidneys that had, like the ureter was obstructed. And so then they'd have infection problems. And so the kidney could get scarred and distorted and look ugly, and they'd get small and shrivel up and not very good looking in that. So
in terms of, so let's say you've got, I don't know, a kidney surgery at like 10 a.m. Tomorrow morning. Is there anything you need to mentally prep yourself for to be able to do those kind of things?
Even after doing it for 30 years, I'd always get up for the operation, mentally. It's like you got the varsity game tonight, and okay, today I got to elevate my game, and I got to be good because doing that, there's just no such thing as little mistakes. They all tend to be big. And so you just kind of have this heightened sense, and the adrenaline gets moving in that, and I think I did that the whole career. And actually, my partner and I talked about it, that even after doing this 35 years, we'd still get nervous and get up for it and that. And we sort of decided, well, if you didn't, it was probably time to retire. But you had to bring your A game. So.
From the moment you started, you specifically, till you were done, how long does a kidney transplant take place? Let's say you're just taking one out. What's it like the time for that?
Oh, to take one out?
Sure.
Yeah, to take one out, usually it was, the sequence would go, you'd go to the operating room at 7:30. By the time you put the patient to sleep and did the sterilization stuff, positioning and everything, and started the operation, by the time we got all the instruments in, it was usually about 10 minutes after 8. And then we do the operation then, and usually the kidney, we were able to have out of the body by between 8:45 and 9 o'clock. And then we'd take the kidney to, a table in the back of the room, and then we'd run, a cold solution through that would make the kidney metabolically inactive. So when it's outside the body, it wasn't forming the byproducts of metabolism that it couldn't clear. And then we do some work on it to get it technically ready to be able to put in somebody. And so then we'd go back and make sure everything was okay with the donor. Look at everything. Put the stuff we'd moved around, the colon, the spleen, back in its proper place and close. And so usually they'd be out of the operating room by 9:45, something like that, by 10 o'clock.
But you said position the patient. Like, are they laying on their stomach, on their side?
Yeah, normally they're laying on their side, so that because with doing it laparoscopically, you have to create a space to work in, and then that helps the intestines to fall away and be out of the way.
What risks are there for the person donating a kidney?
The biggest risk of the operation was bleeding complications, because you're working around deep in someone's abdomen and places that are hard to get, and you're relying on a lot of very technical instruments to work properly. And so sometimes we had equipment failure, and sometimes the anatomy, even though we did all these studies ahead of time, it wasn't always straightforward, and especially the venous anatomy could be different with everybody. So, and that's why, experience becomes so important, though, because with experience, you learn to anticipate the variations and what's normal and abnormal, and so that you can help avoid it. So with time, our complications were much, much less.
Now, in terms of, how many years did you do trauma surgery also? Same amount, 33?
Yeah, 33, yeah, something like that. I think I quit taking trauma call after 33 years.
It's all right. You tell her I say hi. And what's the worst trauma surgery you remember?
I think the worst one was I had a young, she was between her junior senior year in college, and during the summer, it was June, and she was working driving a road compactor, getting a road ready to be, and she got too close to the shoulder of the road, and and those are one of those those big roller things, right. and the thing tipped over and rolled over on top of her, and kind of rolled across the middle of her abdomen and pelvis and out one side. And so she just had, just tremendous injuries of, like her muscles of her abdomen were cut in half, her bladder was transected twice, her pelvis was just, dislocated. She ended up, basically, she had, muscle damage to her thighs and which, and blood supply issues. And she ended up losing her bladder, had a lot of nerve damage in that. I think we operated on her every day for like 21 days in a row. Jeez. And, she survived. And, she survived. So.
And then, the weird question that I prepped you with was, do you actually ever get uncomfortable eating kidney beans?
I am uncomfortable always being presented with kidney beans and never eat them.
Yeah, or any beans. That's
correct. But it's because they're mushy.
That's exactly what the question said. Thank you so much for doing this. Tell Becky I say hi.
Okay.
Great night.
Will do. All right. Say hi to the kids and Amy.
Will do. Bye.